hope you're in mood. Just put
Might be
your
able to
thumbs
see.
up if.
I do, but I think I'm seeing the second. Is there two things on this slide or just the introductory slide? I think I might be seeing the next slide coming as well. So
Oh,
I might,
okay. So let me
it's look like it's full
make
screen,
sure that
yeah?
I share the correct screen. So share screen, it's desktop 2, and share.
Still seeing, do we have, is the slide have, Derek,
Yeah,
I
and
still,
this slide is okay, Anne.
okay,
Okay, this is the title slide. Thank you very much.
great, thank you.
Okay, so over the next 20 minutes, I will lecture on the Lirads lexicon and reporting. And I had the privilege of collaborating with many other Lirads members on the development of recent versions of Lirads. And I also have the privilege of being the co-chair with Klaus Verlin of the Lirads Lexicon Working Group. I'm very grateful to our team members for their contributions, and today I'll summarize the work that we've accomplished over the past few years. By the end of my lecture, you will understand how the Lirads lexicon was developed. You will be able to describe the structure and content of the Lirads lexicon and its companion atlas, and you will become familiar with the Lirads reporting templates. The literature on liver cancer is very vast, with more than 10,000 peer-reviewed manuscripts that have been published since 1970. So the desire to develop a lexicon stems from the observations that there are many discrepancies in terms of terminology used in the liver imaging literature, and also discrepancies in the definitions for the same terms. Here are two examples of why we need to standardize reporting. On this image, we have pre and arterial phase of T1 weighted fat-saturated MRI images, which show non-rim arterial phase hyperenhancement. If we look at the literature, there are at least 11 different terms that have been used to describe the same imaging feature, or AFU. And this is a brief example of terms encountered. It's not intended to be exhaustive or comprehensive. Let's take a look at this other example. How would you describe this imaging feature? On the top row on CT, and the bottom row on MRI. Both show a reduction in enhancement from an earlier to later phase, resulting in hypoenhancement of the mass relative to the background liver. We could call this washout appearance, but again, in the literature, there are at least 7 different definitions of the same imaging feature with differences in interpretation. So there are some consequences to this inconsistent terminology and definitions. First, it can cause ambiguity in the communication between radiologists and clinicians, and potential misunderstanding of the results by the referrers. From a research perspective, this complicates the extraction and pooling of data from the literature, the conduct of meta-analyses, and the replication of research results. In terms of publication, it also leads to inefficiency since manuscripts must devote space to definitions. So the long-term vision of the Lirads lexicon is to provide a standardized vocabulary for liver imaging in 3 settings: education, research, and most importantly, in clinical care. And over time, we've also expanded the context of use of the lexicon from a narrower context of patients who are at risk for HCC to liver imaging in the general population. Let me illustrate this concept thanks to a beautiful slide graciously shared by Claude. The Lirads algorithms apply to patients with a high pretest probability of HCC. In other words, the Lirads population is described by the polygon, which includes adult patients with cirrhosis of all causes except congenital and vascular disease, as well as adult patients with chronic viral hepatitis B. Whereas the lexicon is intended to apply to all patients who undergo liver imaging. Now, this schematic summarizes the relationship between the various components of Lirads and the lexicon. So previously, we've touched on various algorithms which cover surveillance, diagnosis, and assessment of treatment response for various imaging modalities. These apply to the Lirads population. And the core concepts surrounding these algorithms have been expanded in core documents and described in detail in the manual. We have extracted 83 key terms from the core documents and manual into the lexicon and defined these terms. A spin-off product of the lexicon is the atlas, which I will show you in a moment. Also notice that the lexicon is embedded, it is used throughout the report templates. Also, early versions of the lexicon, as well as future versions of the lexicon, will be embedded in ontologies, such as the RSNA informatics ontology known as RADLEX. In the manuscript cited in the reference below, published by Victoria in European Radiology in 2022, we made 3 recommendations. We encourage the use of standardized terminology by authors of manuscripts on liver imaging, the adoption or the promotion of the use of this standardized terminology by journal editors and reviewers, as well as the use of the lexicon in clinical care by radiologists. We anticipate numerous benefits of adopting the Lirads lexicon, whether in education, research, or in patient care, mostly to enhance clarity and improve consistency in clinical communication. This diagram illustrates how the lexicon terms have been defined and how they will be updated over time. The step 1 was to identify potential terms to add or modify by the lexicon and writing group. We then proceeded to iterative development and refinement through monthly meetings. And when deemed ready for review, we submitted these to the lab steering committee. If these terms are approved by more than 90% of steering committee members, they are adopted. If not, they undergo iterative refinement. And now to present a brief review of the European Radiology paper published by Victoria, whose title is Liver Imaging, It is Time to Adopt Standardized Terminology. The lexicon itself is available on the ACR website. It's available free in the form of a PDF table that you can download at the URL below. Let me walk you briefly over the column headers and the structure of this lexicon. On the first column, we list the various terms in alphabetical order, the 83 terms from arterial phase to washout. How convenient. Then we provide a brief definition for each of these terms. We specify the context of use, whether it's broad, pertaining to liver imaging at large, or whether it's Lirads specific. We describe the applicable imaging modalities, provide general comments, and also Lirad specific comments. We list synonyms that we have encountered in the literature, and we define or mention the type of term. For example, whether it's a general term, whether it pertains to imaging phase, feature, contrast agent, vascular phase, or technical terms. And then the date of approval in the event of future updates. The lexicon is currently divided into 4 tables. The first one is modality agnostic, and the others pertain to specific imaging modalities. Here is a screen capture of the definitions themselves without the general comments and Lirad specific comments. So you can see that at a glance, it's very brief. It's about a 15-minute read, and it's a worthwhile investment of your time. This slide summarizes the 83 terms that are currently approved. In the interest of time, I have selected a few of them for illustration purpose, and I will show you some slides from the Lirads Atlas. So the Atlas captures some of the elements on the lexicon table, with the exception of general comments and Lirad specific comments that are left in the presenter's notes in a PowerPoint document. So for example, the Lirads major feature refer to imaging feature used by Lirads in assigning Lirads 3, 4, and 5 categories, reflecting the relative probability that an observation is an HCC. And then on the right-hand side, we include either a schematic or sample cases that illustrate the concept, along with references to the content at the bottom. So you can see that for CUS, this includes non-REM-AFI, size larger than 10 equal or larger than 10 millimeters, and non-peripheral washout. The major imaging features are the same for CT and MRI, plus gradual growth and enhancing capsule. Arterial phase hyperenhancement, or AFI, is defined as enhancement in arterial phase more than the liver, resulting in brightness higher than the liver. We can see that it applies either to an observation in a whole or in part of an observation. You see the schematic on top in A and an example on MRI on the bottom, showing the AFI phenomenon. Washout is a dual concept. It is defined as reduction in enhancement from an earlier to later phase. So there's a temporal concept resulting in hypoenhancement relative to the liver. So there's a comparison between the observation itself and the background liver. Earlier in the Q&A session, someone asked whether a hypo to hypo constituted washout appearance. In the schematic, we can see that according to the Lirads definition, this would not qualify because it does not enhance in arterial phase. Targetoid refers to target-like morphology on CT or MRI, where the center and periphery of a mass have different imaging characteristics. This can be observed with different contrast agents, for example, with extracellular contrast agents, revealing either peripheral washout or delayed central enhancement. This can be seen with gadolinium disodium, a hepatobiliary contrast agent, showing a targetoid appearance either in portovenous phase, in transitional phase, or hepatobiliary phase. And it can also be seen on diffusion-weighted imaging on the bottom row. Nodule appearance is an ancillary feature suggestive of HCC. It consists in the presence of a smaller inner nodule within a larger outer nodule. And it is thought to be pathognomonic for appearance of HCC, a focus of HCC within a larger dysplastic nodule. Hence, here you see the genesis of an HCC. Mosaic appearance is a companion concept which refers to the presence of any combination of internal nodules, compartments, or septations within a solid or mostly solid mass. It's thought to represent clonal expression of malignant cells with different mutations or molecular abnormalities. And I'll finish with fat in mass more than adjacent liver, because someone in the Q&A session asked, what about in phase and out of phase? It refers to the presence of fat in a mass more than in the liver. According to some series, the presence of intravoxel fat can be encountered in 15 to 40%.
I totally did it personally.
Oh, Victoria, you're unmuted.
Victoria, can you mute? Sorry, Victoria, you. Can you mute, please?
Or I think we can mute her. All right. According to series, the various series, the range of fat and mass seen on in-phase and out-phase imaging ranges from 15 to 40%. So it can increase the sensitivity or the confidence in the diagnosis of HCC. Okay, by now, the Lirads CT and MRI algorithms and core documents have been translated into 14 languages, and the lexicon is already available in 7 of those languages. I'm a strong believer in translations because they refer to common terms and common concepts. So for example, in French, on a daily basis in Montreal, I might dictate envahissement tumoral intraveineux. My colleagues or friends in Vietnam might call this khối u kiong tin mạch, but they both refer to tumor in vein. More importantly, we assign a category, or LRTIV, regardless of language, and this facilitates the extraction and pooling of data without ambiguity in the setting of individual patient data meta-analyses. Lirads is now available in 14 languages, spoken in these countries, covering almost 2/3 of the landmass on Earth. Okay, so summary of the first section. Our long-term vision is to standardize image acquisition, terminology, reporting, and data. The purpose of the lexicon is to be used in different settings, whether research, education, or patient care. And this completes my first section. So far, we have focused on imaging features. In the second half of my lecture, I will focus on reporting and data system. And I will highlight some of the benefits of structured and standardized reporting. And in the next slide, I'll differentiate these two concepts. We believe that using both will improve clarity and consistency in communication and link the various imaging features with the actual disease stage, which will facilitate management recommendations in clinical care. In a research setting, this approach also facilitates data extraction, computation of diagnostic performance, and the pooling of data. Now, what's the difference between structured and standardized? The first one pertains to form, whereas the second one refers to content. So, for example, in terms of form, we propose structured reports using a predefined format shared as a reporting template, which is organized in sections in a specific order. Whereas for content, we have reached consensus about the standardized content of the radiology report to promote uniformity, both in terms of language and categories that are assigned individual observations. So here's an example of the sample report template. In the interest of time, I will only enumerate the various sections. So there's procedure, indication, comparison, technique, choice of intravenous contrast agent, the rate, the findings, and the impression. I will focus on a subsection of the findings. In the Lirads scheme, we advocate reporting up to 5 of the highest categorized Lirads 4, 5, TR, and Lirads M observations, which should be reported individually. Additional observations may also be reported, but in aggregate. For each observation, we recommend reporting the size, the location by Quino segment, the series and image number, the major features contributing to Lirads categorization, the ancillary features, if applicable, and the corresponding Lirads category. So this flows logically over time. Lirads provides two templates for untreated observations. The template on top, template A, is a structured text in a single continuous paragraph, whereas the sample template B is a structured report with keywords and findings. Both present the exact same information, but let's take a quick look. The structured text in a single continuous paragraph lists the observation number, the size, either in millimeters or centimeters, the Quino segment, along with series number and images. We then explicitly list the presence or absence of the major imaging features. We optionally list the ancillary features if present, and then we assign a Lirads category. The sample template B is perhaps more interesting in a research setting, although some centers adopt it clinically as well. It's more structured, and it lists explicitly the keywords on the left, which can be thought of as questions, along with the findings on the right, which can be thought of as a set of allowable answers. So for example, is there threshold growth? The answers might be yes, no, or not applicable if you don't have a prior examination. Over time, over the past 2 decades, there have been many advances in HCC treatment options. You can see a plethora of treatment types on this schematic. Some of these are non-radiation therapy and others require radiation. We are now aware of different imaging appearances over time for these various treatment options. So it's become very sophisticated. To mirror this sophistication, we provide 2 report templates for assessment of treatment response. Again, sample template A in a single continuous paragraph, and sample template B present the same treatment response assessment, keywords and potential answers, but in a structured way. I would like to draw your attention to the type of most recent treatment. We'll list on the top row non-radiation therapy, and on the bottom row radiation therapy. We also know that the appearance evolves over a period of months, hence the importance of reporting the date of most recent treatment. Let me present a couple of examples of how these reports are used. So this vignette shows a cirrhotic liver with a 22 millimeter mass located in segment 6, which is intrinsically hyperintense in T1. On the bottom row, we can see that there's AFE along with washout appearance, most conspicuous in delayed phase and capsule appearance. This mass is virtually identical or isointense to the background liver in T2, and it presents mild signal hyperintensity on diffusion-weighted imaging. This is what the report would look like using template A. Notice the assignment of Lirads 5 category or definite HCC. This is the same information presented with template B in a more structured fashion. As for Lirads 1 and 2 observations, they may be reported at the radiologist's discretion. They may be reported in aggregate with the following exception that Lirads observations that were previously reported as Lirads 3, 4, or 5 should be reported individually. As an example, this is a giant hemangioma occupying the entire left liver, along with smaller hemangiomas in the right lobe. Diagnosis is straightforward. These are multiple hemangiomas, and they can be described in aggregate using the plural numerous Lirads 1 observations. An optional reporting element is the staging, which helps link individual observations with the overall stage and which guides the management according to your local institution preference in terms of staging, whether it's BLC, whether it's radiology, T-staging, or TNF. The general concept is that T1 and T2 observations are usually eligible for curative treatment, whereas, whoops, I lost one of my screens, whereas higher stages require either downstaging or systemic treatment. Optional reporting elements include management. So the beauty of Lirads is that the risk of HCC or malignancy increases with higher categories, and this allows us to associate categories with potential management options and guidance. We encourage the use of cautious terms or the use of conditional with words such as options, possible, may be considered, so as to avoid binding the referring physician to a particular treatment approach or investigation approach. So in summary, I've discussed from big picture to detail. We've covered structure reporting. I've mentioned that we have 4 observation templates. We've discussed technique and standard imaging. I've discussed the lexicon, and I've mentioned that it has been translated into several languages. So this is aligned with our vision to improve multidisciplinary communication and patient management. And to conclude, I've also mentioned that we advise optional reporting of ancillary features, staging, and management recommendations, which all display your expertise in liver imaging. And marching forward, the use of this structured and standardized reporting will facilitate multi-center international research. I can take some questions either now or at the end of my second lecture if we run late.
Okay, yeah, we're running a little late, so why don't you just continue on and we'll do the best we can in terms of the questions in the QA and hopefully have a few minutes for questions at the end.
Yes, thank you, Liz. So I'll now switch gear and discuss the evidence supporting Lirads' major features for CT and MRI. So again, in my previous slide, I was a former chair of the Lirads Evidence Working Group, which is now called the Evidence and Research Working Group. I'm extremely grateful to Mohab Elmore, who was back then a radiology resident at Baylor College of Medicine, who worked with all the authors listed above to create an educational lecture exhibit presented at RSNA, which served as the foundation for the lecture that I'll give today. By the end of my lecture, we will review the diagnostic performance report in the literature for major features and for Lirads categories. I will summarize the inter-reader agreement for major features in Lirads categories, and also illustrate the percentage of HCC and overall malignancies for each category. If you're like me and you like to read at your own pace, I would encourage you to take a quick look at these 4 papers covering evidence, a meta-analysis discussing major features by Christian Vanderfall, Lirads 5 by a meta-analysis by Lee and colleagues, and a paper by William Hong on interreader reliability. So Victoria eloquently discussed the Lirads CT and MRI algorithm, which we follow from top to bottom. If observations are not categorized according to the categories above, one of the 3 following categories should be assigned according to the table on the next page. Lirads 3, 4, or 5. We've seen that the major features are observation, AFI, capsule, non-peripheral washout, and threshold growth. So I will briefly discuss each of these in the setting of, in the context of evidence supporting their use. We've mentioned that in Lirads, size is reported and stratified according to different thresholds. Now, size matters for 2 reasons. First, because larger observations are easier to detect, and hence the sensitivity for HCC increases with observation size. On the summary tables, which are color-coded, we can see that higher values are highlighted in red. In general, a higher sensitivity is associated with larger observation size. And also, larger observations are easier to characterize. Hence, the specificity tends also to be higher with increasing lesion size. Now, this is an example of non-rim AFI, which refers to enhancement in arterial phase, which is unequivocally greater, either in whole or in part. Now, when taken alone, AFI has variable specificity, which ranges from 16, as low as 16, and as high as 97%. And notice that the positive predictive value, which we use for interpretation of the imaging findings, range between 59 and 99%. So very wide and sometimes not so great. Then we have the concept of washout, which is a dynamic temporal concept which compares the enhancement from an earlier to a later phase. But also notice that there's a crossover between the enhancement of a tumor, an HCC, and the background liver. Notice that the difference in enhancement increases between the portal venous phase and the delayed phase, hence the interest of the later 182nd phase. Here are some schematics of what constitutes washout in the first 3 rows and what does not constitute washout in the 4th row. This is known as fade appearance, where the enhancement of the observation becomes virtually undistinguishable from that of the background liver. Now for washout, the specificity is also variable, ranging from 62 to 100%, and the positive predictive value ranges from 55 to 100% for HCC. However, when we combine both of these, AFI and washout, this hallmark enhancement pattern has high specificity and high positive predictive value for the diagnosis of HCC. Overall, the specificity is in the range of 75 to 100%, and the positive predictive value is in the range of 87 to 100%. But if we stratify for observation size, we can see that for 10 to 19 millimeters HCC, specificity is high, 90 to 95%, and for observations equal or larger than 20 millimeters, it is nearly 100%. Hence, the rationale for listing patients for transplant eligibility or for treating patients without biopsy confirmation if the Lirads 5 category is met. Enhancing capsule refers to smooth, uniform, sharp border around most or all of an observation. And this is most conspicuous in portal venous or especially in delayed phase. Here are some examples of enhancing capsule on CT on the top row and on MRI on the bottom row. Notice the exquisite tissue contrast on MRI. The capsule itself has a specificity of 83 to 96% and positive predictive value of 96%. However, it has relatively low sensitivity, ranging from 21 to 64%. And finally, we have threshold growth, which is defined as a size increase by mass of at least 50% in 6 months or less. Now, where does this come from? Even though threshold growth has a specificity of 85% and positive predictive value of 65 to 85%, it can inform the risk of HCC, and it's also helpful to dictate the time interval of follow-up exams. This is a graph that summarizes the tumor volume doubling time of primary HCCs and recurrent HCCs from various studies. On the right, you can see that the median doubling time of primary HCC in these studies was 178 days, so about 6 months. Whereas the doubling time of recurrent HCCs is 82 days, so nearly 3 months. And this is used as guidance to justify the time intervals between exams in patients who are at risk for HCC or who have previously been treated for HCC. So far, I have focused on data from single or individual studies. This is a figure from an individual patient data meta-analysis that has pooled data from 32 studies. You can see here for the 4 major features, the odds ratio. You can see that all these major features, non-rim, peripheral washout, and enhancing capsule, have an odds ratio significantly higher than 1. But threshold growth is perhaps the weakest one because it overlaps an odds ratio of 1, whereas the others are independently associated with HCC. This is more or less the same data from the multivariable analysis, along with p-values that shows that the major features, with the exception of threshold growth, are independently associated with HCC. More recent studies since 2020 have pooled the results for different Lirads categories. This meta-analysis from Lee, published in JACR, shows that the proportion of HCC is virtually 0 in Lirads 1 and 2 categories, which is very reassuring. Also notice that the proportion of HCCs increase with higher Lirads categories, and it's 1/3 of Lirads M categories. The take-home messages from this meta-analysis is that the pooled per observation sensitivity and specificity of Lirads 5 was 66 and 91% respectively. Extracellular contrast agents showed higher sensitivity than CT or gadoxetate disodium and MRI. And the Lirads 5 category provides high specificity regardless of the modality or the contrast material type. I love this schematic. This figure from Christian van der Paal's meta-analysis published in Gastroenterology, which shows the percentage of HCC on the y-axis and the percentage of overall malignancy on the x-axis for various categories. It shows that the system does what it is intended to do. It shows granularity with smaller confidence intervals, and it shows higher risk of HCC and malignancy from left to right. It also confirms that the risk of malignancy is high for Lirads M, with 93% of malignancy, and it does not preclude HCC encountered in 1/3 of Lirads M observations. As mentioned earlier, Lirads categories are linked to management recommendations. And now in the final section of my lecture, I will briefly discuss inter-reader agreement. There's an abundant literature, but it's summarized here on this dense slide, in which I have reproduced a meta-analysis from Kang and colleagues. The key teaching points are the following. On the top row, in purple, you can see that most studies show almost perfect agreement for observation size and typically moderate agreement on major features in Lirads categorization. The study type, the study design, and the clarity of blinding to the research hypothesis affected the level of agreement. We know that the agreement on Lirads categories is substantial, 0.73 for MRI. We know from an inter-reader reliability study on Lirads categorization that the agreement is similar for MRI and CT, but it's somewhat higher for studies performed in a research setting than research studies using clinical interpretations, perhaps because of higher, more rigorous methodological standard when performing a prospective research study. Now, this table summarizes the inter-reader agreement for category for Lirads MRI 0.70 versus other RAD system. Not to preach from my choir, but you can't argue with success. You can see that the inter-reader agreement is quite high for the Lirads categories and for the system that has been developed over a period of over a decade. Lirads can also be used to predict longitudinal evolution. This is summarized here in this paper by William Hong, showing the evolution of Lirads categories over 32 months. You can see that the risk of progression increases with Lirads categories. The majority of Lirads 2 observations are either stable or decrease in category over time, whereas Lirads 4 categories have a higher potential for category progression. This idea of using Lirads categories for prognostic, for predicting the outcome over time, is also confirmed by this other study, which followed patients over 48 months. Same conclusions can be drawn from this schematic. This is my final slide, which summarizes the major features. Size has a higher likelihood, has higher sensitivity and specificity for HCC with larger observations. The combination of AFI and washout provides very high specificity and PPV for HCC, especially for observations. When present, capsule occurrence is highly suggestive of HCC. We know that Lirads 5 category has very high specificity and near perfect positive predictive value for HCC. We have moderate to substantial agreement for Lirads 5 and M. We must keep in mind that even with Lirads M category, up to 1/3 of observations end up being confirmed HCC. And we now know that Lirads categories can also predict the risk of progression to malignancy over time. Thank you very much for your attention. I'll be happy to join the discussion panel.
Thank you so much, John. Just gonna leave up just for advertisement for the next series. But we ran out of time, but so we have just a few, I think one or two questions I can add, I would say is, let's see, this is interesting. Phonologist comments that at her institution, they did an audit at their center and 30 to 40% of Lirads progressed to Lirads 5 in 2 to 5 years. And that the Lirads 3s, 30 to 40% also progressed. So it's very interesting data. I would love to see that, hopefully, publish that. I do want to ask you guys questions about about infiltrative lesions and how you handle that with Lirads. I know that's a challenge with Lirads. So either you or why don't we start with on that one?
Yes. So in the interest of time, I did not cover all the entire atlas. We can differentiate two types of widespread disease. There's either multifocal or there's infiltrative disease. We tend to report this in aggregate. In terms of suspecting it, I think that MR is especially helpful because we observe signal characteristics, either mild to moderately hyperintense in T2, similar to the spleen, which helps us detect this infiltrative disease. Also, another helpful feature is that it's often associated to the presence of tumor in vein. That's how I would approach it for infiltrative disease.
Great. Thank you. Any other questions that anybody else, the panelists have? I know we were talking about extracellular versus hepatobiliary contrast agents. I don't know if you had any comments on that as well.
Yes, I do, and I would refer the um, the readers, the whole audience, to the beautiful Lirads manual that has been led by Victoria and Claude. So if you download the Lirads manual on the ACER website, there's a chapter on hepatobiliary agents. You can jump directly to possible advantages of these agents, and they're beautiful schematics created by Victoria and Claude. I really like this one, which shows the hepatocarcinogenesis steps from left to right. You can see that the relative arterial flow increases with small progressed HCC and large progressed HCCs. So that's what we assess with extracellular agents. Whereas the relative expression of OATP decreases early HCCs, and which could be potentially detected with hepatobiliary agents. So conceptually, I think this schematic is extremely helpful to justify the rationale for the possible advantages. There are also potential disadvantages that are discussed later on in the interest of fairness. So, for example, the dose is somewhat lower. So the arterial phase is not as crisp. There are some respiratory motion artifacts that are associated to this. And also in terms of ambiguity, you have to make sure that you're not misinterpreting a small hemangioma as an HCC by making sure that the signal does not follow the blood pool rather than a hypointense appearance in the hepatobiliary phase.
Thank you. So we have Claude on. Was able to join us for a few minutes. Claude Sterling, thank you for joining us. I wanted to just ask, I think, while we have you here for the last question, and sort of a two-part question is what we can learn from the Indian population, what would we like to incorporate, how, going forward, how do you see Lirads going globally? We've done the translations. What's the next steps for Lirads to sort of make it applicable beyond just the US and North America population?
Well, first of all, thank you all for inviting me. I'm sorry that due to some childcare related things as well as some work related things, I can't be here the whole time, and I'm going to have to leave in a minute. This is a really interesting question, Liz. So I think there's a couple of answers to this question. So one is we would encourage radiologists to the extent that they can to adopt Lirads in their clinical practice in India. We hope that if you do adopt Lirads, you give us feedback either by contacting Victoria or Liz or me or anyone that you feel comfortable contacting that's a member of Lirads with feedback on what's working and what's not. What suggestions do you have for how we can potentially improve Lirads? If you're particularly interested, I would encourage you to join the International Working Group, which is currently co-chaired by Liz and me and a few other radiologists here in the United States. So please do consider joining the International Working Group. Please also consider contributing to education. So in the same way that you saw some wonderful lectures today by some of us, please consider giving your own lectures. If anyone is interested in having lecture material on Lirads, I am willing to share essentially any and all Lirads lectures I have ever personally created with you. So just email me. I'm happy to send them to you. My only requirement is that if I have a slide that says it's courtesy of someone else, that you not use that slide unless you get permission from that person. But any slide that I've created, you can use any way you want. And finally, I would encourage you to do research on Lirads. I'm very interested, for example, in Dr. Sonal's experience of the institutional audit, looking at the progression of Lirads. We are developing an international registry to facilitate international research collaboration. This is the kind of study that would fit very nicely with our international registry. So if you're potentially interested in contributing to the registry, please contact me. I'm sorry for the very long-winded answer. I hope you can hear my excitement. I'm really excited by the possibility of collaborating with, and not just me, but all of us collaborating with radiologists in India to facilitate the adoption and inform the improvement of Lirads based on your perspective and feedback. So thank you, Liz, for that question.
Thank you so much. So just in summary, I think that's really important points in terms of we'd like to educate. This is part of the purpose of this webinar, and educate the educators, the potential educators. So that's very important to us. And then we'd appreciate that as you start to use Lirads in your practice, that we please feel to give us that feedback. And also we'd love to see your published feedback in terms of your experience, and in future to do more collaborative work through this registry and other potential resources we have to share data as best we can, within privacy issues and other issues that we sometimes encounter, but we're trying to overcome those barriers and break down those barriers as best we can. But there's many ways that we can do this research, even if we can't share images per se. And the different populations may have different applications and adjustments for Lirads, so we understand that. So we look forward to that, sharing that information with us. So I'll just let the floor open. Anybody else want to make any comments? I know I'm over time. I thank you everyone for their attention and their time. I know it's an evening for you guys in India, and so thank you so much for taking time out of your already long and busy days, I know. And you also have childcare issues, I'm sure. So thank you so much for inviting us, and thank you so much for listening for this long evening performance.
So we wanted to thank everybody. It is amazing, and we really look